I don't know to present the next speaker. I leave it to Nicole.
A very special thank you to our next speaker, my Dr. Sofia BALAMOTI, for accepting our invitation and joining us today. We are really honored by your presence, and I hope that you will be an indispensable part in our initiative to better integrate the medical and engineering fields in improving our living standards. Ms. Sofia BALAMOTI is a European board certified breast surgeon who had her training in the UK and has recently relocated and started practicing in Athens, where she is affiliated to a number of private hospitals and breast units. She holds a medical degree from Aristotle University of Thessaloniki and has a background of obstetric residency. She also has a master in obstetric medicine from the Medical School of Kapodistrian University of Athens. Her clinical interest is breast oncology and reconstruction after breast cancer surgery. Ms. Sofia BALAMOTI, thank you very much.
So, good afternoon to everyone. My name is Sofia BALAMOTI. I'm a breast surgeon. I'm very happy to be here this afternoon. Thank you for the kind invitation to the chairman, to the president of ASHRAE, himself being here. I'm very honored. I'm going to be discussing on how to make surgery a safer place for everyone. So I kind of prepared a short CV to introduce myself, but I'm pretty sure you've already heard that. My clinical field is breast surgery, and I have been certified by the European boards. So, I have no disclosures on this presentation. And a short overview of this talk is that I'm going to be referring to the history of medicine, focusing on surgery, and what are the landmarks in the evolution of surgery, what are the challenges that we as surgeons face today, what's the input of engineering in our field, and I'm going to be closing with some technical videos that I hope will be to your interest. So, to begin with, a history of surgery, because we have to differentiate surgery from medicine, and it is stated that where medicine ends, surgery begins. But actually, to make it more simple and in lay words, surgery is the point that we get our hands dirty, or more politically correct, where we get our hands involved. So surgery is a descriptive word coming from hand in French and work, ergon, in Greek. We have the first documents on surgical procedures coming back from 3,000 years BC in papyrus form. So, how did we go from this point, from this surgery in ancient Egypt and the early days of neurosurgery to our days? In the medieval surgery, I have to make a point, because I'm pretty sure you're all familiar with the barber pole. It's very popular today, but it is actually also very symbolic, because in the medieval ages, barbers were surgeons of the time. And the barber pole with the red and white stripes is very symbolic in a way that it symbolizes the blood in red and the white towels that the barbers used to perform a variety of surgical procedures involving pulling teeth, bullets, and also bloodletting using leeches, which they preserve in the silver balls that they have in their pole in the upper pole and the bottom. So I came to realize that cutting the hair for a barber was just complimentary. They had a variety of more, their work was very, very vast. And I could not help but mention my personal favorite on the Sweeney Todd, which I recommend is a very good movie and illustrative of that era. So, What are the landmarks of surgery? First on my list and on my mind is the introduction of anesthesia in the mid-19th century with ether and nitrous oxide, so as to avoid little poor fellows like this having to have an amputation of the leg under no anesthesia at all. So this is a milestone in surgery, along with the introduction of the significance of aseptic technique and the use of carbolic acid as the first antiseptic, and the establishment of the germ theory by Louis Pasteur that led to producing disinfectants of the surgical wounds. So a lot of other steps have been taken along to come to this more realistic depiction of how surgery was performed in the early 19th century by Sir Robert Liston, the famous surgeon of the era. And I don't know if you notice anything unusual, because we do now know that the anesthetist is there and they have started the gas they use for anesthesia, but I don't know if you notice that there are no personal protective measures for nobody. They don't use masks, they don't use gloves. So this is another milestone in surgery, introduction of gloves, so as to act as a protective barrier to prevent the transmission of diseases between healthcare professionals and patients. Also, we started transfusing giving blood to our patients and blood transfusion. We also invented antibiotics and electrocautery. By that we can now assure hemostasis, so as to prevent further complications of surgery. All of these led to a more the modern era in surgery, and I'm sure you're more familiar to these images. As you can see, a modern operating theater with everybody well equipped, dressed in their scrubs, wearing masks, gloves, a lot of monitors and screens, LED lights, surgical lights, and on the left you can also see the multiple arms of a robot, of the Da Vinci robotic system used in multiple surgical specialties now. So the list doesn't stop there, of course, it goes on, and there are some true game changers in the modern era of surgery. I'm just referring to the minimally invasive surgery known as laparoscopic or keyhole surgery, which has a major upgrade in robot surgery, only inserted in the late 20th century. This is our era, and we now are familiar with the trying to insert artificial intelligence in surgery. It's tested as an approach to give us real-time information about vitals and hemodynamic status of the patient while we're operating, which is very challenging to me as a young surgeon, thinking of having all this information in my hands and how it would alter my decision making in the surgery. It is all very, very challenging, also with all the innovation in devices, all the machines, all the new the implants when it comes to breast surgery. I'm going to be referring later on to that. But we also you have to think about the safety considerations that arise. And I'm just posing that question because we do have the luxury of having operating rooms like this, brightly lit, with all the kind of machinery and everything. But what do we opt for? Is it the future? And if it's the future, is it safe? Because safety is the cornerstone of the whole session, so we always have to pose that question. And even before this conference and before this session, we as doctors, we always have to turn back to the basics. And there is a basic principle in medicine that is to heal and not to harm, coming from Hippocrates himself, the father of medicine. so we always must prevent fault and be safe in every step that we take. So, let me now welcome you to my role in today's operating room of a breast surgeon, where we do have to deal with implants and biomaterials. And for this, we have to be very meticulous in every step. There is a long list that we need to check before actually starting the surgery. And part of it, there are some bullets here, like we have to check the antibiotics, that everything is in correct dosing, it has not expired. We have to prepare the alcohol-containing skin preparation for antisepsis. We have to ensure minimum theater traffic, and that only people who are involved in surgery are allowed to enter the operating room. We have to minimize the duration of our surgery. We have to try to find, we're in Greek standards, or ensure operating rooms with laminar airflow, double clothing, conductive warming for our patient, and of course check all the devices that we're going to use. And why do we have to go through all these procedures? Because there is one big risk. The major risk that we need to prevent is infection. The infection can lead to long-term complications in the immediate or late post-operative setting, and it can create serious problems to us and to our patients that we need to think ahead. So, infection in the field of breast surgery, when we're dealing with patients who are oncological patients and we insert foreign materials, it can be something that can be like a ticking bomb. It can go on to bacterial contamination, to creating a biofilm around the device, the implant, and it can lead to it can just start a cascade of events, like having the patient admitted to the hospital, long stays in the hospital, toxicity from the antibiotics, septic conditions, even loss of the implants and revision surgeries. Now, not to mention, last but not least, that it's not at all cost effective when it comes to health economics. And just to make it a little more illustrative, because I know that this is quite medical already, this is the challenges that we face. And you may have done all the fantastic work reconstructing a breast in a woman with breast cancer, and it all starts with a red dot. A red dot that is spreading, that unfortunately you cannot just manage or handle with the administration of antibiotics that spreads more, and in the setting of an immunocompromised patient can get really nasty. It can lead to systemic infection, to sepsis. It can lead to deconstruction of the whole breast, and in the whole point where we, in the sense that we're trying to help these patients, and ultimately we don't help them, we cause them more problems. So, just to give you some insight on how another complication, very usual complication we face in the implants, and these are pictures of the breast implants that we use, is that bacterial contamination of the implant can occur at a later stage, not only immediately after surgery. It can occur a few years, months, or even years down the line, because the capsule, the film that our body creates to the foreign material, it can be contaminated, it can lead to severe fibrosis and contracture, and ultimately give us really bad, disfigured breasts that also are painful and very uncomfortable for our patients. And this is serious problems for us, breast surgeons. So, just to give more depth to my argument, when I tried to give you a definition of the operating room, I was not really surprised, but but I needed to mention that infection makes part of the whole definition of the operating room, because it is, although we're trying to control the environment, we now know that this is a major thing, infection, and it can happen even in a sterile environment intended to prevent infection. So you may argue that it's a multifactorial, multivariable thing, but I'm here to talk about about surgery in operating rooms, and this is the major issue for us, preventing the infection. And not to compliment you, but I truly think that engineering is science, whereas medicine and surgery is just the application of these positive sciences in total. So when a laminar airflow is something that is standardized in the UK, where I was trained. Unfortunately, it's not standardized in Greece, but we were looking for laminar airflow operating theaters to do these cases of implants or breast reconstruction. And when I got back to the basics, and I'm going to read with you, the laminar airflow is referred to as a system that provides continuous flow, uniform in both direction and velocity. So in real life model, it is like rivers or canals, and it was very clear to my mind, because I'm not an engineer, so I'm not familiar with how you define with your terminology, but it made sense to my mind. So what is the laminar airflow in the operating room? It's an airflow that uses positive pressure air currents through filtration units to direct airstreams away from the operating field, and all this in order to create an ultra-clean zone around the operative site. And there is more information about the HEPA filters on my videos in the next slide. So I'm going to share them with you.
Laminar flow ventilation systems were pioneered by Sir John Charnley in the 1960s and 70s, resulting, when used in conjunction with other strategies to reduce sepsis, in a reported marked decline in post-operative wound infection. The practice became widely adopted in orthopedic theaters after a series of trials that showed a significant decrease in infections from laminar flow theaters. However,
So, I must say at this point that we, as in breast surgery, we have taken the advice and the experience of the orthopedics, because all the research and all the published studies are in part of the orthopedic in orthopedics, but we have the same principles when dealing with these implants. Move on.
So why is laminar flow used in operation theaters? Laminar flow theaters aim to reduce the number of infective organisms in the theater air by generating a continuous flow of bacteria-free air. In laminar flow theaters, air may be changed in theater more than 300 times per hour compared to standard positive pressure theater rates of 15 to 25 times per hour. Laminar flow systems are also capable of generation levels of colony-forming units in the atmosphere below 10 colony-forming units, CFU, per cubic meter of air. The number of particles in the theater air is also lower than in turbulent systems.
More insight on that.
Work in an operation theater. A laminar airflow unit works by the use of inflow laminar air drawn through one or more HEPA filters, designed to create a particle-free working environment and provide product protection. Air is taken through a filtration system and then exhausted across the work surface as part of the laminar flow process. Commonly, the filtration system comprises a pre-filter and a HEPA filter. First, the air goes through the pre-filter or panel filter. Next, the fan blows the air toward the HEPA filter. The HEPA filter captures the dust, bacteria, and airborne particles. Therefore, the HEPA filtered air is clean and particle-free.
Just one more.
Types of laminar flow. Laminar flow systems operate either by a horizontal or vertical system. In horizontal laminar flow systems, high-efficiency particulate air filters are installed on the totality or part of one of these operating theater walls. Such a system is easier to install, especially in existing theaters, but requires correct positioning of the operating team in order to be effective. The vertical
I don't know if you noticed that they do mention how the staff, the team, is going to move around the theater. So minimize the personnel, the people involved, is crucial. And we use signs outside the operating rooms that it's strictly not allowed to people who are not involved in surgery. So it is something that we cannot measure, we cannot tell that we had an infection, we had a complication because of a lot of people coming in, but we do know that it is a significant factor for us.
Configuration involves ceiling-mounted HEPA filters, which direct air vertically downwards into the operative field. Individuals at the periphery of the airflow may prove disruptive, but it is less dependent on scrub team positioning. Entrainment of flow can, however, occur from theater personnel moving with the periphery of the laminar flow area, deflecting contamination inwards toward the operative site. Both systems can be used with exhaust units, also known as spacesuits, to further improve air quality, but a discussion of their effectiveness is beyond the scope of this review.
All right, and one was hoping that you're not tired from this technical.
Either system works to create a unidirectional flow of air free of eddies and turbulence. What are the components of laminar flow? The major components of laminar flow are the outside tank, inside tank, fan, return air inlet, panel filter, polyester screen, differential pressure gauges, gel HEPA, and diffuser lamp. This was the simplified video on laminar flow used in operation theaters.
And this would be my last slide. I hope that it was interesting to you, and thank you very much. I hope that I have made an argument on how operating theatre can and must be a safer place for all. Thank you.
Questions, discussion? Boy, have I got questions for you, Doctor. If I may, in my youth I was a designer, a consultant for Leto Museum. And I've done design work for hospitals, operating rooms, intensive cares. And I have questions for the medical profession and from the engineering. Do you think that in our discussion on improving the conditions inside a medical facility, do we need to bring a psychologist in the equation that he will tell us what would be better for the patient and for the staff? And I'll give you a small example. When I was a student in Britain, I would go to my dentist, and as I was lying back, he had a childish poster on his ceiling, and I would watch it time and again. That would distract me. I have never seen it anywhere else, and I've been on many dental chairs. So, and I would like to ask both doctors and Sunny if you think that we need to have the expert advice of psychologists in how to improve the environment, the staff, the position of the equipment, all parts of a room.
Should I answer?
Yes.
Thank you for the question. So, yes, I couldn't agree more. I mean, in the design of modern surgical rooms, operating rooms, we do know that making people feel comfortable, and I don't mean the patient because apparently, obviously the patient is asleep, but the staff may have 8, 10, 12 hours a day in this room, making them feel comfortable, making them feel safe, high air quality and everything, can make a difference. Can make a difference to their performance, which ultimately is to the benefit of the patient.
How would you feel comfortable in the operating room? Just give us your personal feeling.
So, from my personal experience, for example, I felt it made a huge difference to me. When I first operated in an operating theater that had a glass window, but not. It was more of a glass
wall.
Glass wall, yes. So I felt connected to the environment, the outside environment, and it was not. It was a landscape. It was not obviously a city in full traffic and everything. But it made a difference. I find myself asking for this hospital, for this particular hospital, and transfer my lists to that hospital, their facilities. It made a huge impact on me.
Okay.
And this was a common feeling for all the staff.
Would you have another factor that would improve your day working in?
Music also in the operating field can be relaxing, and I mean obviously not all kinds of music, but it's our workplace. Our workplace. We spend plenty of hours there. We need to make it feel at home, and in all aspects.
Casinos pay a lot of millions for music that makes you play more.
Exactly. So music can be used as a psychological tool in a lot of facilities.
Yeah, Baroque music at 60 beats per minute.
Yeah, well, it depends. There's closing music as well. So when the difficult bit, the surgery's open, they'll think some closing music now because the easy bit is going to close the wound. In America, the music is one, but in America, you see they will wear different types of surgical hats as well. Get a bit of fun into particularly pediatrics. If you ever go to pediatric surgery. But just the idea, not the operating theatre, because again, I think the surgeons dealing with cancer, that needs to be very clinical, high, optimised for the surgeon rather than the patient. And frankly, if you said, look, somebody's going to operate on your mum's breast surgery, you want to make sure the surgeon's actually optimised rather than when my mum thought it was a bit of a sterile atmosphere when I was in there. You know, but as engineers here, looking at medical innovation, I teach medical innovation in Dublin. A quick story, just to digress, was the CT scanner for children in the paediatric hospital. So we brought focus group in of patients and the mums, and we asked, look, how can we improve the patient journey, the patient experience throughout the hospital? And kids were getting distressed going into the CT scanner, they were moving, the films weren't good enough, so they had to be repeated, so there's unnecessary exposure of x-rays, the kids had to be sedated, so you have to bring them into the day ward. So we actually just sat down and looked, how can we innovate? And the big innovation came from the mothers, and it wasn't a new molecule, it wasn't a new med tech, it wasn't a new machine. It was the idea to make the child a CT scanner under the water like a treasure. So we had fish hanging from the ceiling. When you came in, it was a big adventure, and then you went into your submarine to have the CT scan. And the kids loved it, they would lie still, they were part of the story. So it was an engineering workflow innovation that had a huge impact on clinical outcomes and use of medication. It wasn't a doctor came up with the idea, it was the patient, it was the engineers about how can we actually journey map a patient as they flow through the hospital to have an investigation. So there is lots of ideas when doctors and engineers and journey mapping and design thinking comes into it. You can have a medical innovation that's nothing to do with medtech.
Do you think that a window or a glass opening to the outside world would help you if you're in ICU or in operating room.
I mean, there's lots of examples of, say, biomimicry or bringing nature inside, which is restorative and regenerative. We're seeing natural daylight. IEQ looks at lux, it looks at biodynamics. So there's no doubt having access. I mean, we're all in here, like there's no daylight, and you go to big conference centers in America, it's exhausting, there's no natural light. ISIAC was in Honolulu this year. That convention center is half inside, half outside. And there was a palpable increased energy and good feeling because we could see trees and sky in the daylight. So there's no doubt you can do design thinking to improve the indoor environment.
Would somebody else like to add to this question? Sammy?
Yes. I'm not a doctor and I don't have any experience of working in operating theaters, but I'd like actually to address your question about using psychologists from the public health point of view. When we are doing actually studies, and large-scale studies, then I can see that more and more we tend to use environmental and behavioral scientists because we are following some citizen science approaches, so we do need to know how to speak to people, we do need to collaborate actually with people, with the occupants, and we do need to know how they address their behavior actually in their home environment, and how their behavior may also have an impact on their environmental quality. So I can see that more and more, when actually are working and doing large-scale studies, we don't rely only on the engineers or on public health scientists or on environmental quality scientists, but we do rely also on behavioral scientists in order to give us this aspect.
Thank you. Does anybody else from the audience want to ask something?
Hello, very interesting presentation, thank you so much. I want to ask a technical question, so maybe I will address it to our US fellows. There is a theory that mainly derives from ASHRAE and the US standards that is not recommended to apply laminar flow in operating theaters because the human body and the number of operators that perform the operation, they produce a thermal airstream that goes up and delivers the germs and the pathogenics, and it's not recommended to make a flow adversely because you lead all this contamination, let's say, in the open wood. And according to ASHRAE, it is recommended to make the return of air from the top and supply from a low level. And I was because I gave the chance for effective design of ASHRAE, and I was very troubled what exactly applies, because in Greece we follow, according to the canal, we follow the laminar flow. General, do you know what? Do you have any idea about that?
Yeah, it's been a long time since I designed a surgery suite, but reverse laminar flow are essentially displacement ventilation in an operating suite. Feels counterintuitive, but I have no idea, so I wouldn't want to give you a technical answer that anybody would take action on. It's just, I've always been taught you move from clean to dirty, right? And with laminar flow, I could see where if you're generating a lot of heat, you could get some stack effect or some plumes, but you can do that too by just moving your arm across a laminar flow field and things like that. So I'm sure we need, now that it's been brought up, we probably need to form a group to study it further and actually take some samples and see where it goes. Because, yeah, that's the first time I've heard that laminar flow is not the way to go. Based on the science that it works, I've not heard that. Thanks for bringing it our attention.
I would say exactly the same thing. That's why Dimitri's organising this meeting, is that for that exact point, I don't know. And what you don't like as a doctor is to look stupid. We always like to think we know all the answers, but I'm quite happy, good psychological safety in here. Say I don't know, and it's a brilliant question. I mean, we do wear masks, and we've got a hood on, we've got our gowns on, so the plume and that type of thing should be minimized. But it's a great question, I just do not know the answer.
By the way, if I may, Katia Bougatsou is a resident expert on clean rooms. Her company is called Bougatsou Clean Room Technologies. Okay, and I think I've persuaded her to come to London in February. So we can discuss this matter a little bit more. Me, from an engineering point of view, I think we need to do a dynamic analysis inside an operating room, because people move there, and there are different people, different weights, different heights, and it's not a steady state, but by default. So the first step is not to have excess people inside an operating room, but we need to have it in a dynamic, to observe it dynamically. Otherwise, we do not solve the problem. We think we might be on the right track. And my last question. I know, sorry, yes, please.
Just to add to your thought, perhaps if there was a research project for CFD evaluation inside the clinic, inside the hospital. Perhaps.
That's interesting
CFDs are now top of the notes.
Maybe we need to apply for EC research project and see what. Yeah. Thank you. Any more questions here or discussion? As I was saying before, I know they've told me, doctors and clinic directors, that they said a patient came, I treated him for what he had, but he got an infection and off he went. So my question, I've been definitely to hospitals, from the room to the operating room and then back, do you have a safe passage? Not in my mind, not by a long way. Do you think that we should put emphasis on that? To have a clean room, I do not know how we might call it, not airlock, because they take the patient, they put him in an elevator, by default the elevator is not a clean area. You know, you cannot have it certified as a clean space. Elevators. Oh, well, I'm old technology.
Well, from my perspective, implants are not at risk after a patient exits the operating room, because the skin is closed, and there's also the main where we focus is the aseptic technique, and the minimum time the implant is exposed to the room conditions in the operating theatre. So we're trying to keep that, just to give you a notion of time, we're trying to keep this time below 5 seconds from the moment that we get our implant exposed, served to us, and inserted into the patient's body. So this is the crucial, this is the timeline for us, this is the crucial moment for us. And we also have special equipment to insert the implant by not touching the skin, I mean the wound, because we do know that although we have used antiseptic technique, skin has bacteria. Okay, so the question for me is purely in what happens in the operating room. And I'm not an engineer, as I said, I cannot go into details on the laminar airflow. And from all the research that I've done preparing this talk, the fact is that we cannot tell that laminar airflow definitely plays a major role, because we cannot isolate laminar airflow and use it as a variable to our studies. So, if anything, it may not be as crucial, as important as we think, but I'm not aware of any adverse studies so far. It was on the checklist in the UK, but of course, like in everything, we need to investigate more.
Where do they get the infections then?
Hmm?
Where do they get the infections?
Oh,
and
they do.
Where? In which part of the process? That's maybe the one point that we need to...
In these 5 seconds.
In these 5 seconds, okay.
It's plenty of time for bacteria.
Went off the microphone. We did, he's an ASHRAE who was over, and he has, I think they call it, sorry, if you put it back there, the air curtain, so similar to laminar flow. So the only people within, there's an air knives or air curtain like a laminar flow, so the only people who are inside the air curtain is minimalized, as you were saying, and then they're fully wearing PPE, so you're minimizing any plume. But just talking about the infection control strategies, there's surface technology or surface infection, and then there's airborne infection. Now, surface bacteria is impacted on air, and air impacts on surfaces. They're two different things. So just as the surgeon's saying, when you're looking at wound infection and the wound, you talk about cleaning the skin, prepping the skin before you start the incision, washing your hands, classic Florence Nightingale. The risk is when the skin is open for airborne. So when you're saying taking the patient back, the surgeons close the wound, there's a dressing on here, dressing. When they're then going back, you're really then only worried about respiratory infection of airborne. So you've got to break down infection control to surface technology and airborne. And the risk of airborne infection, sometimes it can be a commensal or something on the skin that will infect the wound during the incision, but it shouldn't be if you prepare the wound area properly. But the risk of airborne contamination is only during theatre. When you take them back to recovery in ICU, unless you're opening up and changing the dressing, you're really worried about surface bacteria, washing hands, surfaces, the instruments you're using. So it kind of changes between airborne and surface depending on the phase of the patient journey.
Thank you.
That was very accurate indeed. Yes. We need to differentiate these two.
Okay. Last tricky question. Do you know from your experience whether we have patient rooms in under pressure or over pressure? And we do need on different occasions to have overpressure in the room if we have, for example, a burnt patient.
Yeah.
We do have specialized hospitals in Thriasio that treat burnt victims, but in the majority of our hospitals, do we have that distinction? I'm talking that because I was in one of the Navy ships, and they had this facility, but...
Yeah. Well, I'd only be familiar with it in intensive care, within the ICU or ITU, an American Intensive Therapy Unit. So if you have a patient with Ebola virus or coronavirus, you obviously want to have a negative flow, so the air is coming in from out, and that air is being exhausted and clean. If you have an immunocompromised patient or chemotherapy or that there you don't want bugs going in, so you have reverse its positive flow, so the air is coming in from a HEPA, almost like a surgery type air, clean air coming in, and then it's being pushed out the door. And those in a really isolation situation, you'd have a submarine door, like a double airlock door before you go in. So generally in ICU, we would have positive flow and negative flow depending on if they're an infectious patient or immunocompromised.
But you don't have it in ordinary rooms, patient rooms?
No. I think generally it will be positive coming out, so clean air coming into the room, and then blowing all the bugs out unless it says MRSA or C. diff or something.
And
like
one last remark probably goes to our president on a discussion with previous Admiral Bablev, that now Admiral Dimitrov holds his position. We were discussing about sensors in ducts. Now they are becoming dirty cheap, you know, $100, $200 or euros, and we need to start thinking of installing them almost everywhere and monitoring them. We have been discussing on that this information has to go to backnet, to an central server, and get the data and be able to react on that. And they have to be upgradable, not put some sensors and then forget them, or put some filters and never forget them. There's another major issue of maintenance of the filters, of the installation of everything that we lack.
You're opening a can of worms that I can talk about all day.
Yes, please.
Okay, so I'll just get, and there's, I feel like there is such a thing as too much data. And I'll give you an example. One of my university clients, the campus has 200 buildings, well over 100,000 sensors. When I was first commissioned by the client to come take a look at their facilities and give them an idea of, you know, their maintenance that was driving their maintenance people crazy. I walked into their management, their maintenance management system, their building management system, their campus management system. And I said, show me your alarms. I got into the system. There were 2 million unacknowledged alarms. Okay, 2 million. They lost all hope of using that system as some positive way to maintain their HVAC systems. I started to print out all the sensors that were in trouble. I printed out 600 pages at number 8 font of sensors that weren't reporting correctly to the system. This is on one campus. If we're going to throw sensors everywhere, this is where I think artificial intelligence is going to help us, because using that to monitor the sensor and know when it's the least bit out of calibration, when it feels like it's not reporting the right information, is the time to get a jump on it. You start getting 10 or 20 unacknowledged alarms, up to 2 million. It's the cry wolf syndrome. People then don't pay attention to it at all, and then things spiral out of control. But it's a big problem, and it's only going to get worse with more and more sensors out there.
I think we can learn from the Navy.
Yeah.
And if I may,
Keep it simple.
if I may, and I hope I don't say anything sensitive, modern warships, you don't press the button for countermeasures. They have, I do not know whether it's an AI or an advanced system that can track 400 or 800 threats and then decide which is the worst case.
Usually in a ship, we have a monitoring of all the systems, and we track all the alarms. Of course, I can say.
I'm talking about the threats, airplanes or.
I mean,
Yeah, like the Iron Dome, right, or whatever.
yeah, usually in the ship we have 2 centers. One is the combat center, which track all these threats.
But it decides on its own or not?
Yeah.
Which is?
Yeah.
Why?
You have to see all of them, not to defend yourself.
so the reason I said that AI is going to probably be the answer.
Just to answer the question
Oh,
about the alarms that of course we have a lot of alarms of the systems inside the ship, I speak, not the outside threats. But usually we deal with them. In some cases we just inhibit them because we know maybe it's a sensor, but the first time we deal with them. If we have a bad sensor, then we just wait to change them. And of course, taking the opportunity to speak right now, you know that a Navy ship and the special Navy submarine is a special environment. We have to deal with a lot of things that we heard here from these presentations. We need to scan the people inside, especially in submarine, for all the bio indications inside all of this. So it's a very good presentation that we here. And especially with the ventilation system, it's a critical system inside the ship. Also in the Navy ship, because we know that Navy ship is a combat ship with closed doors, usually. And so just imagine that in many cases, that is what you mentioned before, we have to deal with nuclear, biochemical environments. So the total ship is closed, and we use overpressure inside with filters that taking the air outside from outside in order to shield the ship from the outside environment. We have leakages from inside to outside, not from outside to inside. Okay, thank you.
What I was going to say, Dimitri, was just an example. One of the universities I'm working with has taken our standard for commission, written 19 algorithms from the standard, plugged it into a machine learning tool that monitors every sensor on the campus. And it continuously monitors, looks for anomalies, writes the work order, sends the work order to facilities maintenance. Facilities maintenance responds to the work order. It then continuously monitors and says, well, you fixed it, or you didn't fix it, go back, take a look again. And that, through that system, and they've only applied it to 11 of the 100 or so buildings on campus, they're saving $1 million.
Okay. By the way, I think that will happen maybe in our next big conference. Thank you both. Kindly evaluate the topic. Thank you, Dr. Balamotti.